Most of the times, we are in the theater, we have a joint replacement placed for the first surgery, and the C-arm moves out because we have a nailing in the next OT. So what's your threshold in complex cases of using a fluoroscopy for a complex THR?
So if you are not sure of your implant placement, I'm just talking broad categories. Usually we don't use it. Very soft bone, you worry about perforation. Revision scenario, have you removed enough cement? Is there something blocking it? These are few situations we need image intensifier, but not routinely. Complex protusio, we want to see, or a fused hip, we want to see how far we have gone medially, though we have pulmonar fat and all sort of things are available. But how to go, which direction to go, then we use image. But not in routine cases, but we have outlined complex cases.
Yes, sir.
So these are the cases.
My question to Dr. Arora, sir. In the severe protusio, how much lateralization, to be done?
How much lateralization?
Lateralization of the cup.
So you template, I told you isosceles triangle, you compare to the opposite side, You compose it to the opposite side, how much is your acetabular offset? Similar acetabular offset you restore on the other side. The opposite side works as a template.
How to replicate on the table? How to
On table. So
that
there is something called, Dr. Tripathi, as mental templating, what I do. Mental templating is, before surgery, see the X-ray extremely carefully, and whatever is visible, the lateral most edge of the remaining acetabulum, I'm talking about protusio side. You see where is the lateral most edge. Either you template or have mental templating, make your diagram a horizontal bar, 45 degree, and you see before surgery, you understand before surgery, how much cup will come outside that margin. And similar thing you reproduce on table. I hope I have conveyed the message I wanted to convey. Preoperatively, have mental templating, where is your cup will be, how much outside it will be, the margin, or it will be inside the margin, the bony margin, you're seeing the lateral most. And on table, you reproduce that. That works very practically in my hands. That I so call it mental templating.
I think you can use the CM when in doubt. There's no problem in that. And you can always take the CM from the other OT, just have to put the new covers and then put it back, no problem.
So with protusio, I always want a rim fit. So in protusio, the most important thing is that your rim should not be, damaged in any way. So when I start rimming, the cup which gives me rim fit, I stop at that. And that is normally my lateralized, means that is enough lateralization. It's not much lateralized with that. So that is how I do it. And as Dr. Arora has also mentioned, you should have once you start doing, you have that mental templating that you have seen the X-ray, you know how much, the cup is going to be proud a little bit or not. So that of course is there. But
rimming has to be done because in the divergent,
huh?
when the mouth is very small and it
yeah.
is very capacious, then
so that is,
the rim has to be a little bit.
So that is why I'm saying that once you start rimming, you have that feel when it starts gripping. So you start, suppose at 44, 46, 48 normally. The moment you have, because I have had, instances where, the rim was damaged, or because in a protusio, if your rim is not fitting, if it is damaged, then it becomes very difficult to manage. Yeah.
The inside is always wider than the rim.
I was talking of use without technology. Image is always at hand. Anything you want to verify.
His question was that the image goes to other OT. What should
we always use
I keep
image
intensifier there.
Yes, we always use it.
I think what he has mentioned is the practical thing. Suppose there's an image image should always be handy. So it should always be in the theater, and if required, it should be used. Another thing is we use it in posterior approach. So it's very easy to see. Another thing, it's not like very difficult to see with the image. And as a rule, now all our hip cases now for many years we always see before the patient is shifted out, he is always seen in the image. A simple hip, complex hip, whatever it is. So there is always a shot which is taken before the patient is taken out of the theater.
Hello. My question to Dr. Arora. Do we have any AI help or trauma cord sort of help available for these things?
I have not used AI help or robotic help, never. Okay. I have not used.
So they are available, depends on the availability at your place. That's it. including the AI, the robot, everything is available.
In case you are managing the protrusion, you are aiming to get the fixation in the wall.
Rim fit, in the rim.
In the rim and wall.
Yeah.
Entire rim. What is your take when there are osteophytes there also?
Normally you don't.
You are able to identify osteophytes very distinctly. It's not difficult to do so, isn't so? So this what discussion was going on in the previous talk. Somebody who was doing fused dip was taking osteophyte at the beginning. We just said, hold on. You fit your cup and then you see. So if you are very sure this is osteophyte, you can remove. I always remove it later on. If once you put your cup, anything which is causing
Times
impingement.
it is amalgamated so much that it is overhanging the cavity. So what is your take in that? Would you take put your cup in,
even
and then remove it? How do you do it?
Even your plain X-ray, it is not difficult to identify osteophytes. Isn't so? Superior osteophyte, anterior osteophyte, inferior osteophyte. One can do that. But if you are not too sure, it's a protrusio, you want to save the bone, you don't want to ream, go ahead and do your work. Put your cup on the rim. And then whatever is projecting and causing impingement, you take it off. Not so complex.
And second situation is when you have a bipolar which has acted for long and you have a superior lateral defect which is superolateral protrusio.
Right.
So how do you manage that?
So you...
Lateral protrusio is not that medial protrusio.
Superior,
it's a
yeah.
superolateral.
So there is
I hope you are talking...
defect is there, you mean to say, no?
Superior defect.
Yeah.
So
I've shown you 3 ways of doing it. You can use if it is it's a bipolar, you do not have a femoral head with you, then you need to use a augment.
Use an augment.
Augment or a buttress there. You know,
Augment
if you have
or
bone
allograft.
bank, then you can use a graft.
So it's allograft or augment, either of these two, to fill a structural
If
defect.
it is a contained defect, which graft is better, marcellized or chips, or what graft you prefer?
So the ideal size is 8 to 10 millimeter, not the reamings. 8 to 10 millimeter size is supposed to be the ideal for osseointegration.
So this is a very important point. It should not be totally paste. It's not good. It has to be 8 to 10 mm. So they're little bigger grafts, and it has to be impacted very well. Carefully, and then you have impaction sets now available. Indian ones are also available with which you impact that graft. You can do reverse. See, so what I do is, I impact it, then I do reverse reaming helps. It helps that graft to get, it gets, मतलब वो अपनी जगह पे set हो जाता है. But the thing is that after reverse reaming, again I impact it. Because if you only do reverse reaming, the shear, it's not good for integration.
So don't do reverse reaming. You can use one size less trial and put it gradually. That works very well.
So one question. Most of us, the delegates over here, they are happy doing bipolars for a neck femur. In some of the cases, they usually move in the bipolars. How to predict which one will go in and how to prevent that? They usually move in. They protrude.
Ones which are well fixed will go in. The femur will go in. Or they will, if they are well fixed, they will go in the femur
situations,
or in the acetabulum. So with the bipolar, we face. I can tell you every OPD. Every OPD I see 1 or 2 patients. You should be very clear. Should not do bipolars in younger people. Never. Right, they are going to fail in 4 years, 5 years, 6 years, 7 years. I see patients 25 years, 30 years, bipolar done 4 years back for neck femur, which I think should not be done. If you want to do any replacement, a total hip is going to perform much better for a longer time than a bipolar in young people, in active people. Bipolar should only be done, as sir also pointed out earlier, in patients who are homebound or who are not community ambulators, right? And in these patients also, who would go in and out, that's difficult.
See, there is no way to predict, but then poor bone quality and gradual remodeling with weight bearing will happen. That's a separate story. You are talking of gradual production of protrusio because the medial wall going in. It can only happen if you are maybe anybody putting very tight, that may cause, because we tend to put not tight bipolars. And number two, poor bone quality. And third, I imagine somebody might have done an inflammatory arthritis. I have seen people doing even inflammatory, though not indicated, doing a bipolar fracture neck femur. Soft bone, I think, is the answer. It is not working.
It's demand related, I think.
It is not age, it is function, sir.
It is function.
I've done THR in 75, 78,
Yeah, so-
active. Community ambulators, very active. We talk science.
No, I
We talk science. We don't, at this stage, at this platform, we talk science.
No, I think they should send. So, I think their joint replacement is now very well done in all cities. And there are surgeons who are doing it. If somebody is not able to do it, you should refer it to you or somebody else who will do a total hip. I think putting in a bipolar in a young patient is not justified at all. It should not be done. Yeah.
So I was reading a study. This question is often discussed, though off the topic. Fracture neck femur, when we do THR. This wasn't. So they have done a study. Depending on economics, I'm talking economics, right? So, economics की बात कर रहा हूँ. So number of complications, what are revision rates in fixation versus THR? At the age of 54, you can justify THR in fracture neck femur. This is American Academy paper. So I'm talking of economics. So THR is also justified. If you do a bipolar, then after 5 years again you convert to THR. Think of the agony, think of morbidity, and think of money, everything.
It's the economic of the surgeon that he's talking about.
Actually, those who do the
It is being recorded, right?
bipolar in a young patient, probably they don't come to these conferences. That's the reason.
It's not working. Take this. We can speak.
So in superior defect, when you are putting augment later, how are you feeling for the press fit and the cup?
So for putting an augment, there are two principles to put an augment. One is that your cup is not stable and the augment is adding to the stability of the cup. In that, you need to put the augment first and do a intracavity reduction of the size of the acetabulum, and then that is one way of doing it, right? The other way is when there is a big defect, but the cup has got reasonable amount of anterior posterior stability, but there is a defect there, and you don't want to leave it there because so in that case you put the defect later on, that as I showed you. Yeah.
So in the trial you will be feeling for after you,
Yeah.
in the first case, for the first
For the
scenario,
first case, so if you have a big defect like this oval defect, anterior posterior fine, but medial it's sort of an oval defect, you put provisionally the augment there, put it with 2 screws, right, with the trial in, then you can do a reaming also, just like I showed with the femoral head. You can ream also to have good fixation there. Once the screws are not very tight, then you put in the real cup there, tighten fix the cup also and fix the screws in the augment also.
In the metal case,
Yeah, so with the trabecular metal, that's a problem. So that is the problem that, it has been seen that there is heterotropic ossification over the tantalum throws a lot of bone. That is why, we always put cement over you see in that also, over the surface of the augment. Right?
It is very aggressive.
Very
reduction
aggressive.
conduction,
Yeah.
Very aggressive. So defect to cover the metal cage or either bone taken from iliac crust, or either taking from, if it's both side taking from head. So how to decide the rehabilitation after in the defect is covered by bone graft or defect is covered by metal cage?
What is it? Rehabilitation?
Rehabilitation, how much?
Okay. So
And second thing is how much if the head is migrated superiorly and there is any difference in the limb length LLD? How to assess during surgery?
For rehabilitation, a lot is guided by your primary stability you got on the table. Right? Now suppose, like Vijay has told, that if you are putting an augment which is contributing to the stability of cup,
your rehabilitation will be slow, right? You'll be giving partial weight bearing and depending on osseointegration. Now, if you have used augment just as a filler, there is primary stability of the cup, and you have used an augment instead of bone as a bone filler, then you're not worried much about it. Then you will not modify it, isn't so? So that was your first. Second question was what?
LLD.
Limb length discrepancy. See, in revision scenario, you can't get best of both the worlds. If you get it, fantastic. Your primary, what is going on in your mind at that time, is to get stable construct on the acetabular side. If we are talking of vestibular problems, no? So wherever you get the stable construct, and we accept hip center, don't we accept?
So as far
15 millimeter, 20 millimeter, primary thing is to get stability or longevity of implant. This is what we tell our patient. At least I tell my patient, I am doing revision, I don't take guarantee of limb length.
yeah, so as sir has also pointed out, with revisions, my dictum is my patients don't have full weight bearing till 6 weeks. They are on toe touch or partial weight bearing with the walker, right? So I am a little conservative in my revisions. So, yeah. So that means I don't allow full weight bearing for at least 4 to 6 weeks. 4 to 6 weeks on, they are toe touch weight bearing means I tell them toe touch, it's partial weight bearing, I know, so the only thing is I tell them not to put their heel on the floor. That is the only thing.
So last question, please. We are already overshooting.
2 questions. Like we are discussing regarding THR in NOV. So which one you prefer, like cemented or uncemented? Because literature is leaning towards cemented THR.
Yeah, I think Ramakant, you're right. So if I'm doing, I think it all depends on means how's the bone quality and everything. But cemented, a hybrid sort of thing. Cemented on the femur side and cementless on the cup side is much more safer. But I think you can go ahead with the cementless also. The problem with cementless is some of these patients in elderly are osteoporotic and they develop periprosthetic fracture. There's a clamshell type of fracture which is most commonly seen in these patients. Yeah. Yeah, you can do. Yes, sir showed also. We have also done. So impacted grafting plus cemented, it is a very good bailout option. Very good. And it works.
I thank all the speakers and panelists for enlightening us. We'll have a quick photograph and then move on to next session.